said, I'm a nurse. I work at Butale University Teaching Hospital. I work as IPC nurse. I was a nurse. I did my advanced diploma on nursing. Then the bachelor and masters were done on Masters of Public Health. Today, I'm going to present about the hospital-acquired infection. Those are the definition. I'm not going to delay talking it too much, but let me just start by say something. As we know, generally, hospital-acquired infection is defined being acquired in a health facility day 3 onward following the patient's admission. Otherwise, you will be talking about community infections. Then, as we said, you had asked for us to talk up to say about like two most hospital-acquired infection. Here, we're considering the reporting. We can say that here at Butale University Teaching Hospital, we are observing mostly like E. coli, Klebsiella, but also I couldn't stop to own these two because we are also observing some of the Actinobacter species and Staphylococcus. You can go to the other slide, please. Then we talked about some factors associated with those infections. We have observed that mostly, like most of the infections, are caused due to the immune system of the patients. For age, old, for instance, patient having like diabetes or HIV, while they are operated, it will be mostly they are, for instance, laparotomy. They are, according to research done here at Butale University Teaching, we observed that most of those patients were acquiring like hospital acquired infections. But also, if we consider, for instance, like one of the study done by my director, the Albel, we have seen that some of the patients who had developed hospital-acquired infection, for instance, did not did not wash their hands while they were taking their pill. There are also like some, we will talk it later maybe about some measures. We have observed that during the swabbing, like our cleaners did not clean for instance, the tables, operating tables, the separators of beds, and then anyone who are passing through should acquire those infections. They are main like factors, but now as the main topic today is about the strategies, let us talk about the actions we did concerning we have taken concerning this hospital acquired infection. Actually, before talking about this, let me say that it have been noticed that it is an issue of knowing which hospital acquired infection we are having in the hospital. Maybe if we are relating to the presentation, to the report from the department, because if we consider like the system of IPC here at Butale University Teaching Hospital, we have a permanent team working together. Like I'm IPC nurse, we have another one called Jose, she's also an IPC nurse. We have an IPC officer who is in Sansman Shalom, but we have also an IPC specialist. So, for instance, our hospital is like, it has like main department with about like more than 400 beds. So, like one focal point would not be enough. That's why we have a permanent team. But even if we have the team working permanent, we have also the focal point in department. So that means that every month within department they are reporting the hospital acquired infection. In fact, I'm the in charge of the hospital acquired infection here at the Butaro University teaching. But we have noticed that though they are reporting, but I will talk also a bit about it. We are having, like I can say, in underreporting. For instance, if I consider 2023, the prevalence of hospital-acquired infection here at Butaro University teaching was about 6.9%. And mostly like the ICU and neonatology, that is where we have been observing many hospital-acquired infection, especially like Klebsiella in neonatology. And we had also recorded some death, and that's why I'm going to emphasize about the measures and especially in neonatology. But also in the ICU, we had some like septicemia, and mostly there was staphylococcus, as I said. But as we are doing the swabbing, we sometimes also swab with the hands of our cleaners, and we find out there was the E. coli. So about the measures which we take or which we took, the first measures for us, as I said, was to build a team. Because like before like 20, 21, 22, we had only like one person in the IPC. But my colleague before realized that one person would not control all those infections. That's why maybe they say that it's better, first of all, the first strategy was to develop a team. And then the second was like to develop like the tools for audit tool, like hand hygiene, but still it was not enough. For instance, if we consider like hand hygiene, it was even not about, it was like 10% of staff were practicing, were doing the collectively the hand hygiene. Even if up to now we are trying our measures concerning the hand hygiene, but still we are about percent if we do the accumulation. Another control measures, that was the education to staff, patient keepers, and we gave them the feedback. IPC, maybe lastly, we were like in a training with the WHO staff where they were trying to see how they can incorporate this course in the university because of this issue of not having the IPC course in mostly in the university. We are seeing that some staff, they are not considering like the IPC measures like their own. First of all, they say this issue is about IPC. That's why we are emphasizing on education on the staff and patients, take caregiver, patient take caregivers, because we have realized that, for instance, like these Klebsiella and the what, their resistance germs. Whenever you don't focus on those people, you cannot control it by yourself. If surgeons are not well educated about their importance on surgery, it will not be easier for you to control the staphylococcus and whatever and the Klebsiella in theater. But also another measures, that is the general cleaning. For instance, we know that IPC it's like not, it's a cost measure. Because, for instance, if I consider for us here at Butali University Teaching Hospital, we are spending like more than 300 million on IPC. But we have seen that cleaning, and those are also there's some researchers, that cleaning, general cleaning itself with the water, soap, and disinfectant are really mostly more than 50%. They can play a major role on infection control. And as I have said about Klebsiella, you cannot resistant because they are called resistance because there is a reason. So that's why I prefer to put Septanius among the measures, because I know for of us you are using the general cleaning, water, soap. But Septanius here at Butale University was really among the key element for controlling the Klebsiella. We can continue, please. Another slide. Oh, that's almost the slide showing the 5 moments. I'm not going to talk about it, but I will talk it about concerning the challenge, because some people don't think that hand hygiene can play a lot, but the 5 moments do really play more than we can think. So those are the challenges we have got. I've said before that, first of all, when you want to fight any enemy, you have to know who is my enemy. That's why before fighting hospital-acquired infection, we have to know what I've preferred. You are saying that please try to show the mostly or the likely germs which are hospital-acquired infection which are in the hospital. As I've said, like for instance, the reporting last year was about 6.9. And when we consider in Africa, we can say that it is more than between 10 and 20% of hospital-acquired infection. But why do we get only 6.9? That is because of the reporting. What is being caused by the reporting? As I've said that some of our colleagues, sorry to say that, but mostly like medical doctors, consultants, they are the one who are reporting these hospital. But we have seen that for most reason, maybe we'll talk it in the discussion. Well, we ask them, why do you not report the hospital-acquired infection in the files? Because, for instance, if I have someone who is reporting and a certain department is saying, you ask me to report what? And then some of them said, but we're not finding something in the files. Of course, this should not be the main excuse, because also they have to observe. But also, if it is not documented, it will not be easier to find it. And another challenge was the adaptation of hand hygiene culture. Some of the people, they want, you can find, for instance, I don't know about you, but sometimes we went by surprise, someone is doing like a word round, and you may be like, he's opening some dressing, one patient, second patient, third patient, not doing the hand hygiene, and then you wonder what's happening. So that's, people are not yet developed this culture of hand hygiene. Then the turnover and availability, but also the capacity of cleaners and the cleaning product. We have observed that in last year and last time, that it was not available. Some companies, they come, please, you are supplying cleaning products, what. But when you go to observe, you find out that there are, for instance, there is no soap. There is no what. You ask the department, the cleaning companies, say they say this product, please, 1 week. But when they are delaying 1 week, second week, then you are attracting those infections. And then another challenge that is, for instance, some of the complaint concerning the workload, considering hygiene and infection as IPC property or policy rather than taking IPC as everyone responsibility. So there are some errors. We have observed that, for instance, sometimes some nurses say, please, you want us to measures, but they take time. Do you think that is the only thing we have to do? But we are also doing the advocacy in the administration to recruit more nurses, more doctors, so that people are not complaining. But we have to remember that when something is not your culture, when you don't want to put something in practice, or we know that change also they bring some resistant people because they don't want just to change. And this term for considering like hygiene and infection as IPC property, that is where people say, but there are some people, there is a team, there is one who is in charge for hospital-acquired infection. But we are trying to educate them. We are doing by giving the feedback. Please, you see in your department, for instance, only 50% are doing hand hygiene. Then we are trying to make it their own, not their own responsibility, not just considering it as IPC property. So if we can summarize it, that's it. Maybe we can discuss more if there is anyone having questions, because I see that I'm taking time. I can keep it at that, and welcoming some questions and discussions. Thank you.
Okay. Thank you, Jean Dodier, for a good and short presentation. So let's go to the second presentation. Then the question and the comments will come at the end of the presentation of Dr. Marie-Claire. So, Dr. Marie-Claire, could you share your screen and present your presentation? So then after we will have discussion, comments, and the question from our participant. Thank you. Dr. Marie-Claire? Okay.
Thank you, Dr. Jacques. Can you see my screen?
Yes, I see.
Do you hear me well?
Yeah, your voice is there.
Okay, thank you, Jean Dodier Murganachaka, for an introduction to healthcare-associated infection at Siashibe. It was just a brief introduction about our topic. And for me today, what we are going to see is an introduction to healthcare-associated infection and introduction to infection prevention and control principles. At the end of the presentation, I will share a little bit of the burden of the hospital-acquired infection based on the current literature. As he has mentioned, healthcare-associated infection are one of the most common adverse, but this infection can be prevented. And IPC is a quality standard that has to be incorporated in other quality standards in healthcare provision that ensures safety of patient, staff, and the visitor of the healthcare facility. So in this module, we are going to see the definition of healthcare-associated infection and then different measures of IPC that are used to try to reduce those infections based on the infection cycle. So this is the outline, and then these are the objectives. We are going to identify how healthcare-associated infections are transmitted within healthcare facility. We are going to see the importance of IPC practice, and then we are going to see the hierarchy of infection control and how these control measures reduce the risk of those healthcare-associated infection in healthcare settings. And we are going to recognize some of different challenges that are met in our healthcare facility. But this is as an introduction, as I have said. We are going to go through a little bit as theoretical material, and then you are going experiences. As Jean Dodier mentioned a bit, healthcare-associated infection, which was previously called nosocomial or hospital-acquired infection, are infections that affect patients during the process of healthcare in a hospital or other healthcare facilities, but they were not present or incubating at the time of admission of the patient. When we say other healthcare facilities, it's like pharmacies, laboratories, or other institutions that provide healthcare, but which are not hospitals, because sometimes we take more time saying a healthcare facility being a hospital, but we have some small other institution where we can have healthcare administration. So healthcare associated infection, to say it is associated with the care that the person has received, it must appear after 48 hours or more after the patient admission, or within 30 days after discharge. This definition is applied for all the patients, but when we come to patients with like devices like implant, we go beyond 30 days, we go to 90 days. But the commonly found is between 48 of admission until 30 days of discharge. We don't have to forget that occupational health infection also are among healthcare associated infection, because as healthcare providers, we like to focus on patient and then we forget ourselves. So when we acquire infection while we are treating patient, it is also considered as healthcare associated infection. So the most common healthcare associated infection that are reported and are defined in the WHO guidelines, we have bloodstream infection, which are all three categories. Primary bloodstream infection, the one we like to call septicemia. We have central line associated bloodstream infection, like the one for the patient, like patients who are on dialysis, we have peripheral line associated bloodstream infection. For example, when we are giving the patient a perfusion, they can get infection at the point of the peripheral line we have put in place. We have also catheter-associated urinary tract infection, ventilator-associated pneumonia, surgical site infection, and Clostridium difficile infection, and multi-drug resistant infection. So when we are reporting those healthcare-associated infection, we base on this categorization. And as you have said, healthcare-associated infection is the most common adverse event during healthcare delivery worldwide. We are going to see in the burden that worldwide, in developing countries, the risk of getting those infections is between 2 to 5%. While in developing world, we have this risk increased until to 20%, which means that 20% of our patients admitted in our settings, they are at risk of getting infection. We are going to see at the end different literature, the burden we do have. So healthcare-associated infection are mostly found in patient admitted intensive care units, like neonatology, like ICU, or patient with invasive devices. Immediately understand that patient in ICU or in neonatology, in PICU, they are also having devices like those catheter, like the intubation, but also we have patients like people having urinary catheter with the urinary problem. This is part of invasive device that can also increase the risk of having healthcare-associated infection. But also patients with compromised immunity. We know in our settings that we have many patients with chronic diseases. We have patients with malnutrition, patients with comorbidity. Those patients, when they come in our settings, they are at high risk of acquiring those infections. So why do we care about those healthcare-associated infections? Because they cause patients to stay longer in the hospital. For example, we have a patient who came with unstabilized glycemia, who have diabetes. The time you are administering insulin by injection, the patient can get infected by a multi-drug resistant pathogen. That patient who should stay, for example, 5 days for stabilizing glycemia, now she has to stay longer to treat also the infection that the patient acquired during our practices. They cause long-term disability because some of the patients may even reach the point to have chronic lung diseases, for example, due to severe pneumonia that they have acquired. They may have also severe infection that may result to the organ destruction and then leading to dysfunction. They increase resistance of microbe to the antimicrobials, and they cause additional financial burden for the patient, for the family, and healthcare system. Because if the patient has to stay longer, we can't receive other patients. We have to buy more antibiotics that are not necessary. We have to buy more disinfectant. So it is a costly side effect of our care. But also it increases morbidity and mortality. You have said that. So, but to fight the enemy, as Jean Dodier said, we have to know how those infections are acquired and how we can prevent them. So infections come from microbes, and microbes are found in many places, in the air we breathe, in water we use on our body, that we use in the healthcare setting, but the most common site is healthcare professional hand. That's why one of the major weapons we have against those infections is hand hygiene, which is done properly. So some of these bacteria we found environment are helpful, while others they can be harmful and cause infection. So we have, if we consider a person, we have the microbe that we consider they are outside of their body. We call them exogenous. And we have the microbe in our body. Most of the time we consider like normal flora of our body, localized in different sites, like in the buccal mucosa, in oral cavity, or in respiratory tract. We have some bacteria that help our system to be in homeostasis. So this endogenous source of microbes, they are present in the body and they colonize the patient. For the person who has a good immunity, they are helpful and then they do not cause disease. But when the person's immunity is reduced, those endogenous sources of microbes, those microbes which are inside, which are normally called normal flora, they cause diseases. We have also an exogenous source of microorganisms, which we found outside of the patient body. as you have mentioned, healthcare workers' hands, from the visitors, from the equipment we use, and the environment where the patient is placed. So the infection then can develop and spread in the community or through in the healthcare facility through various sources or routes. So when we talk about the chain of infection, is how that microbe we have found in the environment or in the equipment is going to reach the point to cause an infection. We must have different determinants that has been grouped by WHO into 6 elements that are required to have an infection. And it is called chain of infection or infection transmission cycle, which is a diagram illustrating the interaction between the condition required microorganisms to pass from its source to a vulnerable person and spread among different species. So we have 6 elements of that cycle. We have the infectious agent, the reservoir of those microbes. We must have a port of exit. We must have a mode of transmission. We have a port of entry and a susceptible host who will suffer that infection. So it is a chain. As you see, we have to find out how to break this chain of infection so that we can control those hospital-acquired infection. So these are different definitions of those terms and examples so that you get understand this chain of infection so that we can see where to act so that we stop the spread of this infection. So an infectious agent or a microorganisms, they are of different type. We have viruses, we have bacteria, we have fungi, we have parasites, and they are found in our environment as we have mentioned. We must have a reservoir where those microbes are found. As I have said, they can be on the person or in the environment. In healthcare settings, the person may be a patient, may be a healthcare professional, may be a supporting staff, may be the environment like the door, the air, the room where the patient is found. So we can have environmental reservoir which is dry, like different equipment that we use, like the bed rail, the medical equipment. We have also wet surfaces, like the sink that we use, like those ventilators, they can be indwelling places for microorganisms. We have also medical devices, as we have mentioned, like urinary catheter or an IV line. It can be an area to different microorganisms that can cause the patient the infection. And then you have the environment around the patient. The port of exit, it can be a break in the skin. For example, someone having a wound and then you open the wound, which, for example, staphylococcus, and the pus may spread all over. The staphylococcus which were in the abscess that has been drained, if it is not cleaned well, those equipment and the environment will be soiled with those microorganisms. We can have mucous membrane. You know, some people, if they have any bacteria in their body, they can sneeze, and then from their nose, they can spread the microbe they have inside. We have the hands, we have blood, gastrointestinal or urinary tract. For example, the feces or urine. We have the splashes of body fluid, and then we have the most common cause of infection in healthcare professionals, contaminated sharp equipment or other material. Then we have the mode of transmission. The mode of transmission, it can be direct contact of the vulnerable person with the microorganisms. either the person is in direct contact of the material containing the bacteria. We can also have indirect contamination. For example, when we are going to make a procedure and we use a contaminated equipment, or when there is air contaminated by different viruses. So in that context, we consider the transmission of that bacteria as indirect. For the person to get infected, we must have the port of entry for that microorganisms, either through medical devices or surgical incision, mucous membrane, breaks in the skin. To differentiate the port of entry and the port of exit, we may say that the port of exit, here I have a person who is sick and then is leaving out the bacteria. The port of entry, I have a person who is not sick but is getting the infected material. And then we have susceptible host, as you have said, most commonly vulnerable people are the person with reduced immunity, because many people may get exposed to the same bacteria, but they don't have disease. It depends on the immunity and other factors around. So now, for IPC to act, we have to break this chain of infection. We have to see, can we stop the infectious agent to be in the place where we work? For example, by doing proper cleaning or disinfection. Can we check the port of exit, for example, in case of those diseases like tuberculosis that's spread by airborne, where we need to isolate the patient so that that patient does not meet many people, or we can control the mode of transmission. We can put on the mask to prevent a direct transmission from one person to person. So the IPC measures are put in place to break this chain of infection and reduce people infected by healthcare-associated infection. Therefore, IPC, or infection prevention control, is a practical, evidence-based scientific approach with practical solution designed to prevent healthcare-associated infection that can affect patients, healthcare workers, and facility visitors. So it means that it has proven that if you use the IPC precautions, you can prevent those infections. So IPC precaution, it is divided into two approaches. We have what we call standard precautions and transmission-based precautions. The standard precaution are the minimum or the basic or the first line prevention measures that are applied at all patients or when you are attending a patient who visits healthcare, regardless of the diagnosis or presumed infectious status. And we have the additional, we have the transmission-based precaution. So for this standard precaution, when you decide to apply them or when you see a patient, you have to assess the risk of potential infection. For example, if you are attending a patient with vomit or patient having hemorrhage, you have to apply different measures of precaution. So among the standard precaution, you have 11 elements. We have to do risk assessment. We have hand hygiene. We have appropriate use of PPE, personal protective equipment. We have respiratory hygiene. We have aseptic technique. we have patient placement, and we have the contamination and processing of reusable patient care items and equipment. We have environmental cleaning, waste management, handling of laundry and linen, and then we have safe injection. All these measures are considered as standard precautions. You see, for any patient, you have to check if it's going to cause me a risk. For example, if it is a patient who is vomiting, is coughing, and is bleeding, hand hygiene alone is not going to protect you. When you are going to handle that patient, you may need different type of personal protective equipment. For example, you may need a gown, you may need gloves, and then you may need, for example, mask and face protection. So we have the second line is transmission-based. They are also called additional or expanded precaution because they are used in addition to standard precaution. And they are applied when you know the infectious agent that has caused that infection, or the person is presumably having a given pathology that you already know how the disease is transmitted. They are always applied in addition to standard precautions. They are of three types. We have contact precaution because we have seen, for example, the patient is having a disease that is spread by direct contact. We have droplet precaution and we have airborne precautions. So we are going to go through all these precautions in detail in subsequent sessions, and then we are going to see each component, what are the core elements. In some diseases, like for example, hemorrhagic diseases, we are going to see that though the disease is by contact precaution, sometimes we add airway protection. So it means that in all situations, you need to assess the risk from that patient to spread the infection, and you select which measure you are going to apply. So the IPC practices are designed to break the chain of disease transmission, and they create barrier between microorganisms and susceptible hosts. IPC practices, they work by reducing the number of infection-causing microorganisms present in different environments, as you have seen. They can killing or inactivating infection-causing microorganism. They can act, here we have, for example, the disinfectant. Here, reducing the number of infectious-causing microorganisms present. For example, when we isolate the person having the presence of Mycobacterium in the environment, just keeping them in one room. IPC practices, they can create barrier. For example, when we use the personal protective equipments, they can also act by reducing or eliminating risk practices. For example, when you shift from giving the patient IV drugs, shifting to oral, you are reducing a practice that are at high risk of predisposing that patient to infection. Therefore, those IPC practices, they protect patients against healthcare-associated infection, which ensure the safe healthcare, and then they protect healthcare workers from occupation exposure. They protect the environment from contamination, and they protect the community. Because if you, for example, you do not apply an appropriate waste management system in your setting, you are going to find that the waste are distributed in the community, and those infectious waste, they are going to cause infection in the community. So when we apply IPC practices well, we protect not only healthcare community, but also the community at large. However, to implement IPC measures, we have different challenges that we have to look for. And in our setting, we still have lack of guidelines and standards. They are not yet harmonized. We still have limited IPC knowledge and skills among healthcare workers. As Jean-Paul said, that Jean-Dodier said, we don't have IPC module given in training of healthcare professionals. We have limited compliance to IPC practice at individual level and facility level. Here, I am the mindset and behavior of healthcare professionals. You find that the hospital has tried to bring in different facility to implement, for example, hand hygiene, but the compliance is still low. So we have to change our mind to have IPC practice in our setting. In most of the situation, there is insufficient budget, supplies, and equipment for IPC. As we see in our setting, the cost for IPC is not taxed directly to the patient. It is the facility, while they are doing the priority of the needs, to find IPC as a priority, but due to limited knowledge of the impact of IPC on our practices, we find that in most of the settings, the budget reserved for IPC is very low. We have limited facility administration commitment and support for the IPC activities. We have lack of monitoring and supportive supervision, and our infrastructure in most of the situation are not in line with IPC measures required. However, with these challenges we see on the screen, we have to do something. This is the starting point to know that IPC has an important role in healthcare, and it has a great impact on healthcare outcome. It is on our side to continue to educate and find out how we can improve the practice in general. So if there is no question, or by conclusion, I may say healthcare-associated infections are caused by microorganisms that can spread from person to person or via direct or indirect contact. Healthcare-associated infections are costly to the individual healthcare facility care system. The chain of infection describes how infection and diseases are spread. So the chain is broken by compliance to IPC practices. Standard precautions are primary level of prevention measures. They are a patient at all times. Transmission-based precautions are always applied in addition to standard precaution. So before I go to the question, I may share a chapter on the burden of healthcare-associated infection as it is described in the guideline. Bear with me, I bring in the Word document. Sorry to be a little bit short. Do you see my screen? Can you read?
Yes.
Okay. This was an overview that has been developed during the development of national guidelines. We find that healthcare-associated infection in developed world is between 5 to 10%, while this rate is 2 to 20 times higher in our settings. If it is in developing country 10%, in our settings around 30%, 20 to 30%. And the most common in our country, it is estimated to be between 25 to 40%. You understand that 40% of the patients attending the hospital for other reason, they are at risk to develop infection due to the care they are receiving. You understand how the problem is that much. We have the leading bacteria worldwide. They have been abbreviated as ESCAPE, which mean Enterococcus faecial, Staphylococcus aureus, Klebsiella, Acinetobacter, Pseudomonas, and Enterobacter, as well as Escherichia coli. This resistance, the proportion or the rate of this resistance within the hospital is ranging from 16 to 85%. Here, that if the resistance is around 85%, in coming years, we are not going to have antibiotics that can treat those bacteria. When we come to Africa, we see that the risk or the rate of healthcare-associated infection vary from 2.5% to 14%, but this is based on different papers that has been retrieved from Algeria, Burkina Faso, and other countries. And post-surgical intervention are the most common, probably because they are easily identified, because it is easy to see that there is pus discharge on the incision wounds, and they rate from 10 to 30%. And when we come to our country, we have different papers, and the healthcare-associated infection varied from 11 to 15% in general. And the highest rate of healthcare-associated infection was found in patients in ICU, neonatology, and patients who underwent multiple medical procedures and surgery. Surgical site infection was varying between 76%. You understand that our surgery is not that safe as we think. And 10 to 48% of these surgical site infection are due to cesarean section. So you understand the healthcare-associated infection is a great burden for our settings. The most common pathogen identified in Rwanda, it is E. coli, Klebsiella, Staph, Acinito, Proteus, and Pseudomonas. So this is our homework to find out how we can reduce this infection and make our healthcare safe for not only the patient, but for ourselves, the community at large. I thank you for your attention, and I welcome the questions and discussion. Thank you.
Thank you, Dr. Claire, for good presentation. So now it's time for question and the comments. So someone who has a question and the comment can raise a hand, so then we can go by order. Question and the comment are welcome. No one who has a question or a comment?
My hand is up. My hand is up.
Okay.
Yes. Can I go on?
Yes.
Yeah, thank you so much. Thank you so much. This is Jerome from Siashibe. So I'm so sorry because my interruption, the first presenter I didn't follow well, but the last presenter I did it. Thank you so much, Marie-Claire, for this kind of presentation. It was so good. I'd like to come back on some challenges you presented, especially about limited knowledge and skills about IPC for healthcare workers. I'd like to know if you are looking well in our country, especially in our context, health facilities, we see that some people do not know about those causes of IPC. And I'm asking myself how this cannot be or how difficult it is, which can not allow them to be included among the discipline they are delivered into universities. I mean, like IPC discipline, we why not among other delivered IPC disciplines in university in order to get more or many people who are skilled and in knowledge in the IPC. Why? Because we have like Dr. Marie-Claire, I think as the pillar in the country who has some expertise in IPC. You have Dr. Jean-Jacques, who is a specialist in infectious diseases, and the other many partners from outside. Why this IPC cannot be included into the discipline that are given in a university, and we have many healthcare workers who can follow these courses, and they come up with a professional. Really, we have professional we've trained in IPC. Now, in order to avoid this limitation and this lower skills or lower knowledge in the IPC, and as we are going to make more people who are skilled in this discipline. So thank you so much. I don't know if my question is really clear, but I would like to come back.
Okay, we understood your question.
Thank you so much. Thank you so much. Thank you so much.
Okay. So, Dr. Marie-Claire, can you talk about this?
Thank you, Jerome, for your question. Yes, we found that there is limited knowledge about IPC and it is not incorporated in the professional development in healthcare. But it all starts slowly, if I may say so. In the beginning, when the antibiotics were available, when the resistance was not that high, there were other priorities that the country was focusing on. But as the spread of resistance and the increase of death related to infectious disease, now it has affected people in healthcare. So it starts with the number and awareness of the burden of the problem, and then advocacy. For example, if we go back before COVID and Ebola, IPC was a myth in different hospitals and even hospital at the higher level. But with the coming outbreaks, we have been awakened that IPC is a key element that must be incorporated and must be emphasized in healthcare practices. Therefore, it should be also incorporated in the training. So what we are doing as people have been involved in the control of different outbreaks of course, with the support of the government, Ministry of Health, and the other institution, we are advocating that we have a IPC module incorporated in the different formal teaching, but also in work or in placement of new healthcare professionals. They have to get some introduction to IPC. In addition, we have continuous IPC monitoring and evaluation, how different hospitals are being implementing different principles. So I think for now we are at a good step to advocate, and many key players, universities, professionals, they are now aware that those modules are to be incorporated. And another thing is the availability of the guidelines. Once the guidelines are available, the dissemination also is going to increase the knowledge, the awareness about the burden of health and the need for IPC to be a cornerstone in our healthcare setting. This is my comment.
Well, thank you, Dr. Greg. So this is one of the strategy to respond to the poor knowledge in our facility. So as now we are operationalizing our spoke sites that are at the hospital, we want you to be active to participate in this session. You will share the status of practice and mainly the challenge you have in the facility. And then we will keep learning. So we want to make your site, the spoke site, more active so that you can keep sharing what you learned with your colleague working in your spoke site that are health facilities, so that we can stay together in our digital community to have harmonized practice at a standard level. So as we are lucky to have the DG of the Kigali University Teaching Hospital, so maybe he can give us a comment on this, how he will help us to advocate on. First of all, we want the leaders from this spoke site, so he can tell us how or can move forward to include also DGs. So once we have a leadership team in this digital community, we will be successful in implementation of this Hamwe digital community of practice to harmonize our IPC. So over to you, Tarisis. I don't know if you are there.
So good afternoon to everyone.
Good afternoon.
Good afternoon.
So it is my pleasure to be part of this platform as one of the leading hospital in terms of teaching site and also leading in terms of quality services to vulnerable cases and those who are being transferred here. Most of them has already been exposed to different factors related to the acquired infection. So when they reach this hospital, some of them already have the infection, or they can also acquire the infection from here in our context. So given the complexity, the number of patients we are seeing here, and the gravity and the stay in the working environment, it has been seen that we need to focus clearly on IPCs and infection prevention mechanism across the country. So to answer the question from someone from the CHIB and CHICA should be the leading institution in terms of improving quality of care at large to influence the even the universities, teaching universities to embrace to address some challenges we are seeing during the practices when it comes to the curriculum development. So saying why we don't have these IPCs courses at the universities, maybe this is a call. So we are trying to make awareness for people to see this. There is a gap in terms of training and service delivery. So once we understood this, then we actually will influence the decision maker to revise the curriculum and also to include some key courses in terms of IPCs and others, as long as we are advancing in terms of training and also going through some specialties training across the country. So maybe this platform has been initiated by some pioneers who are here. Others, I think, they're not here today. But the main objective would how can we bring all health workers across the health system to be aware and also to be sensitized and to try to embrace these practices of quality improvement. We have seen this during COVID period, where our health system have been challenged at large, because people, they don't have these practices, they don't have this behavior, even our community, even our leadership. So the experience we gained from this 2 years of COVID cannot be left behind and seeing it as something. It is a foundation where we need to build on and keep improving what would have been already implemented, and also influence our leadership to make sure that we are addressing the health issues across all corners. So maybe at ministry level, I think we are discussing with the Minister of Education, Minister of Health, in terms of curriculum development, and also how can we also try to initiate new courses targeting different levels of health professionals, nurses, doctors, support staff, leadership, else where we can have these interventions to make sure that we can have the impact. So if you look at now to the antimicrobial resistance levels, as Claire said, I think it is beyond what is presenting here, because we are now seeing people actually don't have any medication to treat them. So the resistance have reached a level where we don't have any solution. So we need to be sensitized and be careful in this, and be conscious on that. So one of my observation I was seeing here, maybe even if you are looking at the hospital level, we have more than 60 now hospitals in the country. So people are here, it is almost 25 experts from ICANN, maybe local people from IPC, focal person, expert, not even more than 20. So many as much as possible. So our target group for this time was IPC focal person. So I want to advocate for people who are here to bring all of them come here and discuss together so that we can influence changes in our practices. The second, of course, we are not going to have an impact once the leadership don't going to be involved. So I was discussing with the technical team for the hub, how can we organize a specific meeting with the leadership of hospitals in a separate way to to sensitize them the importance of having or even following these courses to make sure that people they are aware, they are sensitized, they gain new skills, and also they are conscious that there's a danger which need a combined effort across all sectors to be able to address that problem. So maybe this is the starting point. We are just at the second week, even through the third week of this introduction. As long as we move on and we improve this, maybe in the future, God can evaluate how we are progressing and we are bringing people inside. So next time, I promise you to bring at least 2 digits of hospitals to witness what we are doing here, and it's also to help us to mobilize others. But we are not targeting only DGs, even managers, because even if you have a good people, you have those principles, you cannot implement effective IPCs measures in hospital without having this support, because it is very expensive. It is required sources, it require support and follow-up. So this is how I can say at this moment. Maybe during our discussion and the preparation, we see how can we bring them here at the right moment. So thank you very much.
Okay, thank you. Taxis Dejofu, one of the biggest hospital, receiving a high number of patients from different region of Rwanda. So now we are lucky we have executive manager of the Infection Control Africa Network. Anna, so could you please share your insight as we are operationalizing our spoke sites. So today we have initiated 16 spoke sites that are hospitals, that are the district hospital, that are representing all 5 provinces we have in Rwanda. So each province have a representative from this spoke sites. So I would like to welcome Anna from the Infection Control Africa Network. So she can tell us the experience from other hub and other country in Africa, and what she can add, the advice we can follow so that we can be successful in this journey of bring together this digital community of practice of sharing knowledge and fighting against the hospital-acquired infection, as well as maximizing antimicrobial use. So over to you, Anna, Professor Anna, you are welcome.
Thank you very much, Dr. Jean-Jacques. And I just want to congratulate the 2 speakers on their presentations. And I think as you have just started, you will see that as you grow and as people find that this is a safe space for them to share the experience. And I think that's the main thing. We need to realize that, everything is not well. We need to do something, but we need to start small. We won't be able to change it overnight. We will have to be patient, start very small, start with small things like the hand hygiene that we spoke today, big important things, stand with our go back to basics, and then break it up in small things so the staff in the facilities can feel that they contribute. Get their feedback, let them talk to you, what they feel can be done, and get them to be on this platform. It's only an hour and a half, and break your sessions into small pieces where they can say, this is the area where they think they need some more information, so that you address that first and then take it more broadly. We've seen that, and I see Michelle has dropped off now. Michelle is from one of the other eco hubs here in South Africa. And they've also started very small and struggled in the beginning to get people to join. But now, after nearly a year and a half, they really have grown. And people attend their sessions and they want to actually present from their facilities. So I think the main thing is you've started, and I think you need to congratulate yourself. I think this is a huge step forward. You've started taking hands with your different spokes. You are going to identify areas where they want to improve, that they found they can. And especially, you know, we're all in a limited resource countries, that we don't have everything that should be there. But we can look at how can we, with the best to our abilities, with our resources, make and small changes that can be sustainable. And if you get your insight from your staff, their buy-in, and the buy-in from your management and from your Ministry of Health, you will see it will make a change. So moving forward with training, but not just training by giving people information, by making it more practical, that what they see in their facilities is how they can make the changes. It's no use we telling people you have to have X, Y, Z. For example, sometimes you say you have to have running water, you have to have liquid soap, you have to have paper towels. And those are just some of the basic stuff. And then people don't have that. So then they feel, you know, now, but there's other ways that we can address those gaps. And I think, as you mentioned, we've got the DG here on as well. And thank you very much for your insight. I think it's very important that we start with identifying all the gaps, hear what people say could be done, where's the areas for training, and break it up into small pieces so that you can use this platform for that, or have a training session per spoke, where you've got a person that can lead you with that, and we can also help with some of that where necessary. But I'm sure you have some training materials as well, and then take it from there and just see how very small steps forward that you make those changes, so that in a year's time you can look back and see, you know, we've made a change from, say, 20% hand hygiene compliance to 40% hand hygiene. Don't think that you will get to 100% within 1 year. We, even here in South Africa, where I am based, we have quite a good, robust system. We still find that we sometimes only get to 50% hand hygiene compliance. So don't set your bar too high, but don't set it too low either. And congratulate your staff on what they've achieved. Get them to be part of this whole session. And if you've got different counties, each of them have different needs. So get them together to show to you what they want to do and take it from there. So that's all from me. Thank you.
You are welcome. So thank you. As now we are closer to the end, could you please go to your camera and take a picture for today? So I think if you try to go, sorry.
I have a comment to make on the next situation that we are going to discuss. For this program, we have to go through the generalities, but also measuring our practices based recommended by WHO. So next presentation will be about IPC core components. What are the core functional IPC in healthcare setting? What we are going to do, we are going to share with you the tool that is used to evaluate the situation at your facilities, and then we are going to share how your IPC is at your facility. It has different marking. It has marking scheme where you can be, after giving the summation of the points, you can intermediate level, or you are at able to share with you that tool, and then next time you will share how is IPC in your facilities. We are going to select some spoke site, and then you're going to have an overview of those core components so that when you go back, you try to see how you can start to address some challenges even without a big budget. For example, starting with seeing if all the required component you can have something to start on when you are talking about IPC in your facility, and to know where you are in terms of level, basic or advanced, and then to see where you have to put more effort. So that is my comment, and I thank Anna for her inputs about continually sharing the challenges in the settings and helping each other to find possible solution, starting small but dreaming big. Thank you.
Okay, thank you, Claire. So our next session is in 2 weeks. Anyone who has, so before we close, we take a picture. If anyone who has a comment to this program, can say before we close our today's session.
Can you hear me?
Yes, yes.
Thank you for this opportunity. I would like just to thank the Congress and everybody for the efforts that I did up to this point. Just I would like to appreciate the idea of Dr. Tarsis. Maybe most of you they know me. That's they another then they don't know me. My name is Viatori. I was the IPC for a long time, working at the Kigali Teaching Hospital for more than 5 years. And I was working in the country wide. So the challenge we met, it was the readers, they couldn't understand what is the IPC, what the importance of IPC. But the idea Dr. Narcis said that he will be inviting the directors of the hospital to attend the meeting, I was smiling when I had the idea, because I knew that's the cornerstone of because when the IPC is a link to everyone in the hospital. So, but it is regards to the employer and employee. So when the directors, when the managers, when the readers, they're not understanding the importance of the IPC, nothing can go forward. So that's why I'd like whoever has the knows the idea, the power to invite those people and to convince those people, the readers that they want can support and achieve the goal. When the readers are not supporting, the IPC cannot go ahead, cannot go forward. We cannot achieve. And also, I would like to also to thank the idea of the Dr. Craig about the core components that you will be dealing with. Most of people, they just know the IPC, but they don't know the cornerstone. But when they share the cores, and when people, all of us, if we do understand what the core components, it will help us to know where we are going. So really, I'd like to just to appreciate the idea, and to appreciate you also for this idea of bringing experts from the world, where I can say the different countries, the different experts, so that you can share. This will help us to move forward. Thank you so much.
So you are welcome, Viator. So please go to your camera and take a picture. So, please go to your camera and take a picture for today. Okay, thank you. See you in coming 2 weeks. Okay.
Thank you.
Thank you.
Well, thank you so much. It was a very wonderful.